Thank you so much for coming to this great symposium. We're so excited to hear from our presenters. And today we will be learning about impact of Trikafta on anticipated psychosocial challenges. So we really appreciate everybody being here with us today. Okay, so I'm Lisa Scher. I'm a psychiatrist at Stanford. I do have a grant from CF Foundation. And I'm very happy to be co-presenting with Dr. Rushwine today with me as my co-moderator. Okay, so the objectives for our symposium today will be to discuss how Trikafta has created change in sleep and body image perceptions in people with cystic fibrosis. We will discuss how Trikafta has affected fertility and reproduction in people with cystic fibrosis. And we'll also talk about how it has changed medical decision-making for people with CF and maybe can change the CF care model. And I think really this will be the beginning of the discussion, and hopefully it will really generate many more questions that we will be answering throughout the next years. So we are very excited to have our presenters today, where we will be learning about sleep and body image and different approaches to the CF care and decision-making. I'm sure that all of you have already used the app for Q&A, so please ask lots of questions, and we will be keeping the questions towards the end of the session. So after all the presenters are done, we will have the panel discussion here and hopefully have a great conversation. All right. And our first presenter will be Dr. Gross, talking about sleep. I know, yeah, here we go.
Okay, good morning, everyone. My name is Jane Gross. I'm from National Jewish Health, and I'll be presenting our work on sleep aids, sleep quality, and daytime sleepiness in emerging adults with CF on highly effective modulator therapy. I have no relationships to disclose related to this presentation, but I do want to say thank you to our moderators also for inviting me here. Very much appreciated. So just for a little bit of background, cystic fibrosis and sleep. So sleep disturbance is known to be common among people with CF. In one study from 2019, up to 90% of people with CF identified the need for clinical support to improve their sleep quality, meaning they were asking their providers, like, how can I sleep better? A 2020 study found that the factors associated with sleep disturbance in people with CF often include mucus production, gastroesophageal reflux, cough, anxiety, depression, and just chronic pain. That same study also reported that 50% of people, over 50% of people with CF reported marijuana use for insomnia. And so these were people that were self-selecting to use marijuana for improved sleep. And despite the knowledge that our patients are struggling with sleep, there's really limited research on sleep in generally people with CF, and particularly emerging adults with CF. There's also very little known about the impact of highly effective modulator therapy on sleep. And when I refer to highly effective modulator therapy for the purposes of this talk, I'm just referring to ETI. So sleep in emerging adults. So emerging adulthood is a time frame in life from the ages of 18 to 25 years, and it's really a unique developmental period. Our patients in this age range are navigating significant life changes like identity development. They're dealing with going to higher levels of education. They may be transitioning to work. They might be leaving their family home for the first time and dealing with more complex relationships. And they're doing all this while navigating a very complex chronic illness. So young adults have higher rates of insufficient sleep duration. They have more poor quality sleep, and they have delayed circadian rhythms. And this is the pattern that we typically see in our adolescent population as well. So that delayed sleep phase also applies to this age group. And we know that sleep is associated with health-related quality of life outcomes, particularly mental health, physical health, and social health. So I think everyone in this room is very familiar that 2019 presented us with a game changer for people with CF with the introduction of highly effective modulator therapy in the form of ETI. But despite that, again, little is known about the impact on sleep. So our study aim was to characterize patient perspectives on sleep and healthcare-related quality of life in these emerging adults with CF on highly effective modulator therapy. So some of the questions we asked were, what is the prevalence of sleep disturbances in this population? And we specifically looked at restless leg syndrome, parasomnias, and daytime sleepiness. We also queried what type and how frequently are emerging adults with CF using exogenous sleep aids. And so we looked at both over-the-counter medications, melatonin, which is obviously a sleep-specific medication, as well as CBD or marijuana use. And of course, we wanted to know how has sleep changed since starting highly effective modulator therapy. And then finally, does health-related quality of life differ between emerging adults with and without sleep? And how is sleep related to other health-related quality of life domains? So for our methods, we recruited our CF population through the Cystic Fibrosis Clinic at National Jewish Health. Control participants were either peer-referred or recruited through snowball recruitment. And the whole study was completed through online surveys via our REDCap system. And so some of the screeners we used included the following: the sleep disorders screener, which assesses symptoms of restless leg, parasomnias, and daytime sleepiness. We used a sleep aid screener, which looked at the frequency of sleep medication use, again, including over-the-counters, melatonin, and CBD and marijuana. We also queried details on how has your sleep been since starting highly effective modulator. And then finally, promise short forms were used with the healthcare, I keep saying healthcare, apologies, health-related quality of life domains, including sleep disturbances, sleep-related impairment, anxiety, depression, informational social support, and pain interference. And so this is a snapshot of what our participants looked like. So the people with CF are represented in blue on the left, and the controls are in purple on the right. You can see we had 34 participants with CF and 42 controls. And they were very similar, I would say, overall, with the exception of people with CF self-reported as white more frequently, and they also self-reported as being either married or partnered more than our controls. So again, looking at CF subject characteristics, this was a pretty healthy population. Again, we're looking at young adults, so you might expect a healthier population. The mean BMI was 22.6, and the mean FEV1% predicted was 92.3. And you can see the vast majority had at least one copy of Delta F508. This is just a snapshot of some of the classes of medications that our patients were taking. So we wanted just to have a better understanding of were they taking prescription medications that might either be sleep-inducing or sleep-preventing or known to alter sleep, like our SSRIs. So looking at sleep-disordered symptoms, again, our patients with CF are represented in blue and our controls in purple. You can see that people with CF had more frequent complaints of restless leg, parasomnias, and daytime sleepiness compared to our control population. So I'm going to walk you through this next series of graphs. So on the y-axis of this next set of images we're going to look at, you'll see the percent within each group that endorse the use of a sleep aid. And in this case, we're going to see that more control participants reported use of over-the-counter sleep aids compared to people with CF. Also, on the x-axis, you're going to see the frequency of use. Moving from left to right, the darker the pattern, the more frequent the use. So in this graph, although more control participants use or report use of over-the-counter sleep aids, CF participants use over-the-counter aids more frequently. Notably, the CF participants use over-the-counter sleep aids at least several nights per month, while most control participants use them at most once a month. Here, we see that more control participants reported regular use of melatonin as a sleep aid. However, when comparing doses, it's notable that CF participants reported much higher doses of melatonin use. And it's important to note that this is not an additive effect. So increasing your melatonin dose past about 6 milligrams isn't thought to be beneficial for sleep. On this slide, we see that more CF participants not only report using marijuana or CBD for sleep, but most of those who are using it do so at least several nights per week or more. So quite frequent use compared to our control population. Next, we compared differences between the groups on the continuous T-scores on PROMIS measures. Because of the small sample size, we report on effect sizes representing clinical change rather than p-values. And what we found was that the participants with CF reported more sleep disturbances, greater related sleep daytime impairment, less social support, and greater pain. Now, these tables examine the association between the quality of variables within each group. So the darker the cell, the significant the correlation. On the left, we see that both sleep variables are strongly associated with anxiety. Other associations suggest that poor sleep is associated with increased depressive symptoms, less social support, and more pain interference. In the control group on the right, there was also association between sleep and both anxiety and depressive symptoms, although the associations were less strong. And there was no association found between sleep and either social support or pain interference in the control group. Now, on this graph, the y-axis represents the percent of CF participants reporting changes in sleep since starting highly effective modulator therapy. And so green is the percent of those who are better, gray is the percent who report no change, and pink is the percent who report sleep was actually worse. And overall, what this shows us is that over 85% of participants with CF reported either improvements or no change in sleep. Notably, though, to the far right, a third of participants reported less frequent use of sleep medications or sleep aids since starting highly effective modulator therapy. So in summary, this is one of the first studies to examine sleep in people with CF taking highly effective modulator therapies. The study results highlight the importance of screening for sleep disorders, especially beyond just sleep-disordered breathing. There's clearly a need to ask about all kinds of sleep medication use in our patient population, including CBD and marijuana, since that seems to be highly used. Highly effective modulator therapy is reported to either have benefit or no change on their impact of sleep in most of the patients that we screened. And sleep impacts do seem to be associated with more health-related quality of life areas for people with CF compared to our controls. And with that, I have several people I'd like to thank. Dr. Lisa Meltzer is a PhD clinical psychologist working with me on this study. And then we had 2 research coordinators that were also hugely helpful in making this study possible. And of course, many thanks to the volunteers that participated, as well as volunteers that participate in all the studies that are reported here at this meeting. Thank you very much.
All right, our next speaker will be Dr. Emma Lyons, and she's a psychologist at Children's Hospital, Colorado, and she will be speaking to us about understanding body image perceptions and Trikafta use in adolescents and young adults living with CF.
Hi everyone. I'm Emma Lyons. Like you said before, I'm a psychologist at Children's Hospital, and thank you so much for having me here today. I'm really excited to talk to you all about this research that I've been doing over the past year, which has really been focused on understanding body image perceptions among adolescents and adults with Trikafta, or with CF after the initiation of Trikafta. And so this research really was generated through conversations that I've had with adolescents in clinic over the past year about weight gain after Trikafta. And I've really, had kind of a mixture of conversations with adolescents. Some have reported to me that they really don't like the fact that they've gained weight after taking Trikafta. And some adolescents are really excited about gaining weight and have really benefited from taking Trikafta and have noticed the effects. So I was really interested in understanding more, especially if either of these perceptions related to adherence patterns. Okay, I have no disclosures to share with you all today. So we all know that adolescents and young adults living with CF have higher caloric needs and have difficulty maintaining adequate weight due to poor metabolic efficiency. And they also have this added pressure of weight maintenance. So eating more, maintaining weight or gaining weight, staying at the BMI that's recommended by clinicians. And because of this, along with the societal pressure and cultural messages that we receive about our bodies, so namely women should be smaller, males should be bigger or more muscular, adolescents with CF are really at a unique risk for experiencing stress around eating and body image concerns. And research has also shown that among kids with CF and in other chronic illness populations, body dissatisfaction may actually have a very critical impact on healthcare behaviors, such as adherence to medications that promote weight gain or weight maintenance, like Trikafta. But this research is really limited, and there's really no understanding of how these issues might look after the approval and initiation of Trikafta. So my first aim of this study was really kind of broad. So generally, I was interested in understanding how adolescents think and feel about Trikafta, and if any of the effects that they've experienced in their body either promote or hinder their adherence. I was also obviously interested in understanding if weight gain and body image perceptions also impact adherence to Trikafta, or were even an issue that we should be thinking about. And then last, I wanted to understand how all of these issues together may differ between genders. So I recruited patients with CF ages 12 through 25 who received care at Children's Hospital Colorado and who had been prescribed Trikafta for at least 6 months. So eligible patients were approached in clinic, so during medical visits by myself or by members of our psychology team. And I essentially created a questionnaire through REDCap that I gave to patients on clinic iPads. So they took the questionnaire on iPads during clinic visits. It was very easy, took about 10 minutes to complete. And the questionnaire that I created attempted to capture these outcome measures here. So adherence to Trikafta, perceptions and emotions about taking Trikafta, and if these perceptions related to motivation to take Trikafta, so essentially adherence. Any weight and or body image changes that were noticed, and again, if these related to motivation to take Trikafta. Any other bodily changes or side effects. I also included the body esteem scale to assess for body dissatisfaction and esteem. And then I included the figure rating scale. So I'm just gonna talk about this one for a second. The figure rating scale it essentially consists of 9 silhouettes or illustrations of different body sizes ranging from very thin to larger bodies. And patients are asked to choose their ideal body size, and then they're also asked to choose how they currently perceive themselves now. And I'll talk a little bit more about this one later. And then I also collected medical outcomes, so BMI and FEV1, among a few others that I'm not going to talk about today, and demographic variables from the electronic medical record. So these data that I'm going to share with you today are very preliminary because I recently finished data collection, but I wanted to provide you with kind of the initial descriptive outcomes that I found because I think they're really interesting. So just to give an overview of the sample quickly, I recruited 52 patients. The mean age was around 17. There were slightly more females than males. This was, an overwhelmingly white, non-Hispanic sample. The mean FEV1% was about 99%, and mean BMI percentile was about 53. So, kind of right on target of where we would hope they would be. Okay, so to assess adherence, this was one of the questions that I asked. Over the past 2 weeks, what % of the time were you able to take Trikafta exactly as prescribed? And a majority of patients reported high adherence, so in this 80 to 100% range. And I do want to point out that this is a self-report measure, which can be biased, and we know that people tend to underreport non-adherence on subjective measures. So that is possibly going on here. And I also want to point out that because of this restricted range, there's really limited variability in this measure of adherence. So moving forward, I'm hoping to include maybe some more objective measures of adherence. I asked the question, how do you currently feel about taking Trikafta? And as you can see, the majority of patients said they were happy, followed by neutral, which, is good news. And then I included this question as a text box within the questionnaire. So if you noticed any differences since starting Trikafta, what have you noticed? And I will say that weight changes were among the most frequently reported. And I'm just including some comments, so this is a good one. I feel better and I don't sweat out salt like I used to. Also, I gain weight easier, which can be kind of annoying, lol. Improved lung function, improved breathing, feeling energized and joyful, less hospital stays and gained weight. A lot of really good differences, a complete disappearance of any sort of cough, easier breathing, endurance during physical activities, no stomach aches anymore, higher energy level, but it also caused unpleasant difference such as a lot of weight gain. I did not edit that one. Breathing easier, gaining more weight, mood, depression, slight body changes like gaining more weight. So this next question supplied patients with a list of symptom changes after taking Trikafta. And unsurprisingly, weight changes were actually the most frequently endorsed, followed by changes in breathing. So this is interesting to me because it tells me that adolescents are, really noticing weight changes, maybe perhaps more so than changes in breathing or lung changes. Okay, so how do these changes affect adherence? I asked the question, how do changes in your symptoms affect your motivation to take Trikafta as prescribed? And the majority of patients said, I don't really think about my symptoms in relationship to Trikafta. So they're kind of saying, we're not really connecting both of them together. I do want to say this, I got some feedback that this question was worded a little bit confusing, so good note for the future. So then I included questions specifically about body image and weight and how it relates to Trikafta adherence. So I asked on the left here, my weight and or how I feel about my body affects my decision to take Trikafta as prescribed. And you can see that 31% of patients reported that weight changes or body image does affect taking Trikafta. So this could have been kind of going either way. So weight is motivating them to take Trikafta, or weight is motivating them to not take Trikafta. This question didn't really clarify that. So on the left, on my screen it's right. On the other side, I asked, I do not want to take Trikafta because it causes me to gain weight. And 23% endorsed not wanting to take Trikafta because it causes them to gain weight. So this is a small portion of the sample, but it's still something that these patients are endorsing, which I think also is important. So last, I looked at the figure rating scale, and just as a reminder, this scale included the nine illustrations, gender-specific illustrations of different body sizes. Patients rated their ideal versus their perceived body size. And to calculate body dissatisfaction, you just subtract ideal body size from perceived body size, which produces these three kind of categories. So a want to be larger, neutral, and a want to be smaller. So you'll see under the body dissatisfaction graph, a majority of patients endorsed wanting to be smaller. And then on the next graph right beside it is body dissatisfaction, the same data broken down by gender. So you'll see more males endorsed wishing to be larger, more females endorsed wishing to be smaller. That fits with kind of the research that we know about cultural messages and ideals about body. And then when put into a regression, being female was a predictor in the model. So females were less likely to want a larger body, if that makes sense. So I also want to point out before I move on that none of these questions about weight or body image related to any of my questions about adherence. So at face value, patients are reporting these concerns about weight and body image, but they're still assumingly taking Trikafta, which also is what we would hope. Okay, so I'm really hoping this study can kind of be a jumping off point for more lines of inquiry and future study in this area. Really, no studies have examined adolescents' perceptions of what it has been like for them to take Trikafta, or how they feel about their body in relation to, the changes that they've experienced since taking this medication. This study also, captures patient perspectives rather than provider perspectives, and I think it's important to start, giving adolescents a voice in their healthcare decisions. The initial results presented here today tell us that patients are noticing weight changes, and maybe we need to be more sensitive or start thinking about how to be sensitive on how to talk with them about weight changes in relation to adherence. And we do need to understand a little bit more about how exactly this may relate to adherence, or maybe it doesn't. But regardless, I think we should be thinking more in depth about how to have these conversations with patients. And so what does this mean for clinicians? Kind of like I mentioned earlier, we might want to reconsider how we address weight with this specific population, so with adolescents and young adults. And things to consider would be to possibly move towards adopting a health at every size approach when talking about weight, maybe normalizing weight gain after Trikafta. We could start earlier with families talking about intuitive eating and nourishing bodies rather than focusing on BMI. And I know there's a lot of really exciting conversations happening at this conference about these topics, and very excited to continue collaborating with our dietitians and other team members to really start to clarify these issues and thinking about intervention in a way that can foster both body positivity or body neutrality and also adherence efforts to Trikafta, which we know is really important as well. That is it.
Great. So from sleep and body changes, now moving on to reproduction. So I would like to invite Eric Schleich, and mental health coordinator from Johns Hopkins, and he will be talking to us about a multidisciplinary approach to assessing reproductive health knowledge in adolescents with CF in post-Trikafta world.
Okay. Thank you to the committee for giving me the opportunity, and also to my medical team for supporting this, what I call an out-of-the-box type of research that we're doing in a pediatric clinic versus trying to wait until adulthood to address this. I have no disclosures. So the background for this study is driven by these factors. People with CF have a significant improvement in survival rates over the past 3 decades. New medications, such as Trikafta, have increased survival, life expectancy now, more than 52 years. And I find that really significant because when I started in CF in 1995, it was 25 years. So just looking at that number is it's amazing for me to see that. There's definitely been a growing concern over the last few years about the mental health and well-being of our adolescent population. People with CF are now more likely to consider changing their life goals, including developing relationships with significant others and family planning. And this is, we're definitely seeing this in just some anecdotal reports. When I meet with teenagers, just thinking about, I want to go to college, maybe I can get married someday, maybe I'd like to have a family. And then females with CF who are taking Trikafta have been shown to more easily conceive a child. In our clinic, we do have one adolescent mother that was definitely eye-opening for us, and was also, a driver behind this study as well in this effort. And then 98% of males with CF are infertile due to the absence of the vas deferens. Attitudes and overall general knowledge in the male population toward this outcome is not currently known, although I was happy to see 2 other posters, and I think concurrently there's a session going on about, and I really like the topic, or the title was Things We Don't Talk About. And that's definitely, this is one of the things that we do not talk about or had not talked about in our clinic, but now that's different. Discussions of fertility have not been a standard of care within our pediatric CF clinic. The majority of patients have learned this through the internet. Something that drove me to start this study is, an anecdotal report of a male coming in to clinic, and the physician said, I don't know what's going on. He seems kind of upset. Would you go meet with him? And I agreed and went in and sat down, and he was sitting there with his mom, definitely looking more down, and said, I found out online I can't have kids, and that was his can't have kids. I was not prepared to have that conversation at 8:30 in the morning, but we did get through it, and I went back to my clinic saying, we have to do better by these patients. The other driver, which serendipitously was right after I had this conversation, was a blog article by Gunnar Esiason, who most everybody here knows, and I want to read this out loud because it's powerful. The internet taught me about infertility in CF, and it wasn't a doctor. It truly is a problem. There seems to be so much anxiety around having these conversations with growing boys with CF. The truth is that as soon as kids learn how to use search engines, which seems to be happening at younger and younger ages, kids are becoming very privy to real-world information. I was shocked by how many commenters on his blog seemed to either not know about infertility in CF or struggled with knowing the best way to tell their kids. I thought my generation of CF guys had it bad. I didn't know the problem still persisted. The medical establishment needs to work to remedy this with community members in a big way. And as you can see, this is only a year old. I found, too, that when I was approaching patients and talking to them and their parents, that, a lot of the reports I got were, well, we found out at birth, but, after we were just diagnosed and then receiving that, it was just, there was so much going on, so that got shelved to the back. Some parents had struggled with, I'm not sure, how to bring this up, especially with males. And, for the most part, my efforts were received very positively in the clinic. The reasons why I felt like mental health and social work need to be part of this is I just feel like maintaining trust with their team is vital. If patients aren't given an opportunity to talk about this, we may not see it as withholding, but they may see it as withholding or not wanting to have difficult conversations. And our patients can handle difficult conversations. I mean, having CF, you learn how to navigate just difficulty in life from the time that you're very young. Some of it is it might be our discomfort as providers in having these conversations. But that can lead to communication breakdown and poor health outcomes. Females are now conceiving much easier. We've all heard of the Trikafta baby boom, and we need to have better conversations with them to make sure that they know that they can make different decisions about their health, their dating relationships, birth control, etc. And adjustment disorders can develop if patients do not have the correct information in order to digest, understand, and incorporate it into their life. Most notably, I was at an event last night, and I met a physician who's in the adult world, and he was asking me what I was here, doing and presenting, and he mentioned a 35-year-old in his clinic who was just finding out that he couldn't father children in the traditional way. Thankfully with medical advances, that's no longer the case, but I don't think I hid my expression on my face very well. My jaw was dropped, So involving mental health and social work can be critical to improving this. So our study objective and scope was to assess the reproductive health knowledge of patients ages 16 or older who receive care at the Johns Hopkins All Children's Pediatric CF Center. And we are Johns Hopkins South. I forgot to mention we're not in Baltimore, we're in St. Pete, Florida. The primary goal was opening dialogue regarding reproductive health with regard to CF in our clinics and having this ongoing. So I just wanted to kind of shine a light, bring it out, let's just start having these conversations. Our scope were people with CF over the age of 16, and the reason we picked 16 is CF Rise had designated that as the age to initiate, and I wanted to stay within their parameters. Followed in the pediatric CF clinic, willing to answer a standard survey, questions regarding sexual health already used within the CF community, which is the CF Rise sexual health modules. The survey was provided at our main clinic and then our outreach clinics at 2 other sites. And we started in October 2021 and concluded this past October. So our methods, I felt it was important to try and notify patients and their parents before they came in for their next CF clinic appointment. I did send an email. I did not get anyone who opted out as a result of that email, but that was also dictated in the email that they did have a right to do that if they wanted to. The CF Rise was used on an iPad, which if you've used CF Rise, you know how nice it is to have the scores populated for you. You don't have to score. It also stores the percentages, and then it compares against national averages. I was able to run a lot of data from their program. Their program support staff were very, very helpful in getting me different outcomes that they could see on their end that I couldn't see on my end as a user. The section had been previously omitted in transition assessment due to the sensitive nature of the questions, and I'll just kind of normalize. If people are scratching their heads why we're not doing this, it just speaks to our overall cultural avoidance of talking about sex and sexuality with our patients. My medical director was very open in saying, I'm a pulmonologist. This isn't what we do. We're not urology, and my goal was, just to start the conversation, not for us to become all of those things, but I really appreciate their flexibility in putting up with my persistence in this endeavor. The social worker who was not able to be with me identifies as a cisgender female, and I identify as cisgender male. We were the ones who gave the assessment. And to my knowledge, we did not have any transgender patients, although the screening tool does not ask gender identity questions, and I'll just add yet after that. Patients with CF falling below 100% were provided with counseling and educational materials as a results for future reference and prior to repeat testing. I'll show you what we used, and we stayed within our clinical expertise. We were not having medically driven questions or conversations as social worker and mental health professionals. That was referred to physicians for that. We also offered the referral to a urologist for males if they wanted to confirm the absence, because there are 2% of males with CF, depending on their gene expression, that can father children the old-fashioned way is what I call it. And then also referring to adolescent medicine, we've definitely developed a really good referral process for that, because as you'll see, the screening tool not only assesses reproductive health, but it also goes into things like STIs and birth control. And I apologize for the poor quality. I do have some copies of this if anybody's interested in reading this a little bit further. But I did highlight the correct questions by each question. So this is an example of the female sexual health RISE component. And then, let's see, if you want to take some pictures, I'll wait. If you don't have CF RISE, it's very easy to reach out and get an account for your hospital. To my knowledge, it didn't cost anything. And then all the modules are on the program. This is our male sexual health. So these took about 3 minutes to complete, and then reviewing was probably another 5 minutes. We did at the beginning I gave my patients the option to have a parent present or not. Most kept their parent in the room. However, a few, once they started realizing what the questions were saying, asked me to invite the parents out, which we did. Yeah, that was fun. All right, so just keeping this up for a minute here, all the highlighted answers are the correct ones. So after we received the score, sorry, I'm not at that one yet. These are the results. The 34 patients were approached and 1 parent refused. They didn't give a lot of reasons why. I mean, one, it was, well, it's final exams. We don't want too much pressure, you know. And the next time it was kind of like something else. And I just was, okay, I know you're not interested. I'm not going to continue to harp on you with that. But I think the perception of the parent was, I'm not sure if I want to have this difficult conversation with my teenage son. That was just my intuition. 18 performed the second test. It was a little bit difficult to get all of our patients to do the second test only because there were some patients that either canceled their appointment or I may have been in with another patient with a higher need, so I wasn't able to do that follow-up test or the second test. But I did make every effort to send through email. And, you know, all of you pediatric providers and adults, you know that can be really hard to get people to do anything for us outside of the clinic. They're on with their normal life. So we had 12 males and 12 females. As you can see, the first test falls in the national average, and I really like that CF RISE put that in there. And what made me extremely happy was, if you look in the middle, the repeat test, definitely a bump in scores based on our efforts. 2 transitioned out of the clinic before they could complete, and we did not post-test anyone who received 100%, which I think some of them just got lucky. They guessed. All right, so our first intervention was the discussion of the questions that were missed, and I just put the 2 questions that the males commonly missed. And thank you to any CF RISE staff that are here who got that for me, made it very easy. But as you can see, this is really the driver of this whole discussion, is the ones that were most missed are men with CF may father their own children. They didn't get that right. And then also a major barrier to men having children, or what's called infertility, is the vas deferens, a tube connecting the testes to the urethra, is absent. 2 patients that really stick out. One was 18. And again, we're thinking of an 18-year-old male. Had no idea that CF had anything to do with his reproductive health. Another was 20 and getting ready to transition to the adult clinic, and just assumed for most of his life that he couldn't have kids. Either they would wind up having CF automatically, or that he just wasn't able to have kids. He thought the only route for him to be a dad was to adopt. So I just, this was extremely rewarding for me to do, to have these conversations. They left clinic with hope, you know. And also as an effort of this, you know, now our staff is just much more confident and comfortable talking about this subject. So the intervention that we would use is making sure that the patient read what's in red. and then asked us if we had any questions. And if we did, we referred to the appropriate service. These were the questions that were most missed with females, but again, we would go over any that the individual missed. Women with CF have a higher risk of, and then if you can't read that, that's highlighted in blue. Women with CF don't have a higher risk of miscarriage, ovarian cysts, polyps, or endometriosis, nor are they more likely than other women to experience any of these things. So that was actually one of the questions. And then risk factors. Definitely did not get this one, but I like that this was highlighted because it talks about the importance of keeping your lung health, making sure that, we're managing diabetes if they have diabetes, and then also managing healthy weight is a predictor of health of, a healthy pregnancy. So the second part of the referral of intervention was referrals. We discussed options to meet with adolescent medicine, which is, located right upstairs, from our clinic to discuss STDs and/or birth control options. And they do such a great job with that. We facilitate the appointment to just reduce that burden, but also to increase the chance that they'll go and meet with them. For males, discussion of and offer to meet with a urologist for ultrasound to confirm absence of vas deferens. Part of my talk was making sure that they knew that, you could be in the 2%. We have a patient whose father has CF, so it's not 100%. Some of the hesitancy that I had heard, in professional circles and even with parents is if we start talking about this, then this is going to encourage kids, my boys, to go out and have sex with anyone. And as we know through I'll call our country's failed efforts at sex education, talking about birth control and using condoms does not have the same outcome. So again, a lot of the attitudes are flawed, but we get to stay comfortable in our little bubble if we don't talk about it. And so it's time to get uncomfortable, is what I would say. So we had, males had expressed interest, but we haven't had anyone follow up and actually report back their findings. So for future processes, we'll continue to provide the knowledge and assessment tool in the clinic and provide open dialogue with all providers, patients, and families. As patients reach 16, we'll provide them with the assessment tool, offer the intervention, and repeat within 6 months where appropriate. And just personally speaking, I think 16, if we could move that down a little bit and even make it about, I don't know, 14 seems, that's just a number that continues to come out to me. But I have had some patients that would need it even younger. We'll provide information to other disease groups within our institution regarding this process, discuss need to address adolescent attitudes towards fertility and family planning, as many of our previous pediatric-only diseases now reach adulthood. When I worked in HEMONC briefly, there was never any talk about harvesting eggs or banking sperm before treatment, before the chemo would actually maybe harm some of that. So I would look forward to sharing that with other specialists as well. And then improving our referral system to urology is another goal. These are our references. Again, please check out that Gunnar Esiason blog if you have a chance. And questions and answers. Thank you very much.
Thank you, Eric. Our next speaker will be Dr. Kimberly Cantor. She's a research scientist and pediatric psychologist, and she will be talking to us about experiences and decision-making with highly effective CFTR modulator therapy, preliminary findings from her qualitative study.
Hi, everyone. Good morning. I'm Kim Cantor. I'm a pediatric psychologist and researcher at New Morris Children's Health in Wilmington, Delaware. And it's a real pleasure and privilege to be here, and I've really enjoyed the talks before mine. So thanks for staying for us too. I have no conflicts of interest or financial benefits related to this. I don't know why that was all caps. We are really fortunate to have support from the CF Foundation through a clinical pilot and feasibility grant to be supporting this work. I want to just acknowledge and thank the study team, Dr. Ambika Shenoy, who's the co-PI and pulmonologist, Dr. Aaron Chittikel, and then our really awesome group of research coordinators, Kimmy, Michelle, and Catherine, who allow us to do this work. And most importantly, and as always, people with CF and their family members, as well as the care team members who have participated in the interviews described here so far. So, right, setting the stage for this talk, just like many others, I think a lot of us were at the last in-person meeting, which the timing was could not have been better. And safe to say, I think that CF care has been revolutionized to some extent by new, highly effective CFTR modulator therapies. I'll refer to them as HEMT throughout, and I do just want to acknowledge initially, over the course of this study, we've had some conversations about, is calling them highly effective modulators the best way to explain it? They're not highly effective for everyone. I want to just acknowledge that, but regardless, I'll refer to them that way throughout. And we have a growing real-world experience and scientific literature highlighting the significant impact that these medications can have on health outcomes. Despite the life-altering potential, though, there are important needs regardless of modulator eligibility and status. To say a little more about that, right, patients who are eligible for these therapies face uncertainty and the potential of a very different future. I think through the psychosocial programming this year, we've heard about how, more time or better health is not always experienced as a unilateral positive, and we felt a need to acknowledge that and understand that. Patients who are ineligible may feel left behind and also face uncertainty about the future. There's also a subset of patients who may postpone or decline HEMT, and we want to understand these experiences also. So that is the premise of our study, that the introduction of these modulators represents a transformative moment for the CF community, and regardless of eligibility, we wanted to understand the experiences and the medical decision-making process of individuals with CF and their families. We also wanted to understand the care team experience so we can characterize and understand how we can identify and address needs as they come up. There are the weird capitals again. So we framed this study through a model called the Ottawa Decision Support Framework, which is a well used in the healthcare context, a shared decision-making framework that frames our whole study. Just briefly about this model, the Ottawa Decision Support Framework basically says that there are better decisional outcomes when we identify the needs of the person making the decision and we provide them with the appropriate supports. And I want to just note here too that a better outcome doesn't necessarily mean taking a modulator in this case. It doesn't mean the outcome that we as the provider might want, although it can mean that, but it means a choice that aligns with the values of the person making the decision, and that is more likely to have, better follow-through and uptake if it's a value-aligned choice. We are conducting interviews with children, adolescents, and adults with CF, as well as parents of children who are eligible and taking HEMT, ineligible and eligible but not taking modulators. We're conducting all of our interviews remotely, telehealth or by phone, transcribing, coding, using thematic analysis, and we ask questions across several domains that are framed by that decision-making model. Should have said this at the title slide, but something I've always loved about this conference is how research is presented at different stages. As a scientist, I think it's important to be able to disseminate early on, and I say that because this study is very much in progress. So we're wrapping up year one of a 2-year project. So I'm excited to share results, but this is in progress and findings are preliminary at this point. A little more about our coding process. We're using directed content analysis. So we wrote a code book based on theory as a team, and then that code book was refined many times as coding unfolded, informed by both the interview and that theoretical context. We're summarizing coded data into themes using an Excel workbook where a different rater reviews the coded transcript and pulls out key pieces. And then our ultimate hope is that this data will inform the development of patient and provider resources to help have these conversations in clinic, to help guide medical decision-making and facilitate more open and helpful conversations about these medications. So this is our target recruitment at the offset based on estimates. With qualitative work, we conduct interviews until saturation is achieved, so these are estimates, but we were roughly hoping to recruit what you can see here, so about 20 to 30 patients and caregivers across the 3 groups, and then 10 to 20 multidisciplinary providers. At the time that I put together this slide deck, this is what our actual recruitment was, so you can see, not surprising from a population perspective and who's eligible. We were quite successful in initially recruiting from our eligible and taking group. We actually, for the adult subset, have likely achieved saturation with this group, but recruitment has been a little bit more challenging with our ineligible and eligible and not taking groups. We initially were recruiting with certain partners through the connections to the Success with Therapies Research Consortium and across the Nemours enterprise. We've since opened up recruitment more broadly than that, and you can stay tuned at the end for how to help us out. But this was our actual recruitment as of a couple weeks ago, and it hasn't changed very much since. So what I want to talk about next, and again, just a note that this is very preliminary, so we'll ask that this not be, I don't know where people would share it, but not shared at this point. Emerging early topics. So I'll give some overall feedback and then walk through our specific subgroups. So a range of experiences have been represented. So for many people, what we might initially think would happen when this medication is approved that you've maybe been waiting for your whole life. For some people, the decision to start these therapies is not experienced as a choice or presented to them as a choice. Some people said, basically, yeah, duh, why would we not take this? Some people felt like their healthcare team presented it like that to them, and that wasn't necessarily expressed as a bad thing, but there was definitely a subset who felt like, yes, this is obvious, we've been waiting for this for a very long time. There were others who the decision was more nuanced than that. So we heard things like people wanting to see more data, maybe hearing things from friends or hearing things online about more mixed experiences that made them a little bit hesitant. Decisions are typically informed by care teams, so people talked a lot about how much they trust their CF care teams, how they go to their team to talk through these decisions, and the broader CF community. So that would include the CF Foundation, but also more informal online or social media groups. From our provider interviews, and I'll say more about this, but we heard that also, perhaps not unsurprisingly, care team members have personal beliefs about these therapies and also reported practice changes in the context of these new modulators being available. And across the board, across groups, we heard people really feeling like there's a need for guidance about the broader treatment landscape, changes, potential changes to care regimens in the new era, and individual decisions about treatment. So what I want to do next is just show a couple of quotes or emerging themes from these subgroups. So in our HEMT eligible group, it might not be surprising to see things like this, but it still strikes me, at least when I'm reading an interview and I see someone say, yeah, this is a fun question, I almost feel like I don't have CF anymore. We also heard, maybe positive but more mixed things like, and now it's like people don't even realize you're sick anymore or that you have a chronic disease, which is great, don't get me wrong, but it's just different. My husband, if I'm tired or feel run down, he's always like, you have the cure, don't worry about it, you're fine. And I'm like, I still have CF. So I think there's some mixed feeling really grateful and healthy, but also acknowledgement that, this isn't a cure, I still have this disease. We heard, just reinforcing that idea that it's not always as straightforward or obvious. People express things like not being sure if living longer is always a benefit, real concerns about possible side effects on physical and mental health, feeling like stopping HEMT would be letting people down. So people said this about their family and also about their care teams who they've known their whole lives and feel like would be disappointed if they didn't want to continue. And we heard, and this has come up in other sessions too, concerns about insurance and other benefits, including eligibility for things like disability, but also concerns about just the cost of these medications and paying for that over the course of a lifetime. From the ineligible group, we heard some things emerging as well. Again, fewer interviews so far here, but we heard this fear of being left behind. We heard people, trying not to focus too much on the treatments that weren't options and feeling like there's still a lot of hope about research and there are going to be options for me in the future. There just aren't yet. We did, initially we were considering parents of children who would be eligible when they're older but are ineligible due to age as the same group with other ineligibility, and there are likely some differences emerging there. We heard from parents, feeling relief and joy that their children's futures are likely to be very bright, due in part to these medications, but also feeling like they were just kind of on edge, like when is she or he going to be old enough? When is it going to go down? When will he be 6? What if something happens before then? So just some mixed emotions there. And providers, these interviews have been, everything has been interesting, but I've loved reviewing the provider transcripts also. We heard, mixed things from providers too. So you can see this quote. I feel like with the older CF patients, I'm more likely to ask, what are you going to do and what are your plans? Well, I may have been a little bit more hesitant to bring those topics up in the past. We heard, and I think it's important as providers to acknowledge that we do have beliefs about this, right? If I think we've all had experiences of patients who were likely to be listed for transplant or were not applying to college because they weren't sure how much longer they'd be around, and now all of a sudden are living full lives, or people who were not able to benefit from modulators. And those things impact the way we feel about these therapies, and we heard that coming out. I have a hard time having conversations with patients who don't think they're sick enough to start the modulator, or I'm having a reaction to a patient who doesn't want to get started. It's hard to justify not really encouraging use. And we heard from providers as well that things like fact sheets or information to standardize guidance about prescribing these therapies, but also things like, how do I answer a question from someone whose lung function is 120% predicted and they're not using their vest anymore? How do I tell them they need to keep using their vest if this is what they look like? And feeling like there's inconsistency maybe in how centers are giving guidance and wanting clarity there. and just some mixed feelings about information sharing online. So feeling like it's great that there are these communities where people talk to each other, but also perhaps sometimes there are things that people are encountering that that aren't supported by the evidence, and wanting to know how to talk about those things. So just again, some initial lessons learned. This is a large qualitative study about halfway through. The interviews have been informative and varied, and it's our hope and our expectation, I think, based on what's coming in, that the final data will help meet a need for the CF community, which is always the goal of our research. Again, recruitment of individuals in certain subgroups has been a little bit more challenging. And, we thought about different research designs, like an open-ended survey, which we may have gotten more initial recruitment, but feel like these interviews are giving us such rich, important data. And it's been very just exciting and interesting to talk with colleagues from centers across the country about how to best deliver care in an evolving treatment landscape. And on that note, if you would like to participate, either for yourself as a provider or help us by sharing this QR code with your own clinics. I'm impressed with myself for knowing how to generate a QR code for this. So if you'd like to take, you can just hold your phone up. It'll bring you to our red cap. So we'll be delighted on Monday morning if we have some new folks to reach out to. And that's it for me today. So thanks again for your time.
Okay. All right, so now I'm going to invite Rika Van Seters to talk about highly effective modulator therapies and the impact on the well-being of people living with CF and implications for the CF care model.
Great, so as Liza just said, what we're going to talk about in this final discussion is the impact of highly effective modulator therapies on the well-being of people living with cystic fibrosis. So this work has been funded by the Cystic Fibrosis Foundation. We're really thankful for their support. I also want to start out by giving thanks to our study team, many of whom are here in the audience. I know some of them are in other presentations, but if you're here, I would love to have you to stand up. It gives everyone a chance to look around and see who it is. So I know some of you are here. And then I also want to give thanks to all the people with CF and the parents of children with CF who participated in our study. And we had a really large group of people participating, much higher than we were anticipating. And I know that many of those people are probably at their homes right now, but if there's anyone in the audience, we'd love to acknowledge you as well. So continue on. All right, so the background, I know you've been hearing a lot about this at this conference, but highly effective modulator therapies can slow or prevent the progression of pulmonary disease among people with cystic fibrosis. However, there's a need to understand the impact on quality of life and to identify implications for the CF care model. So kind of the impetus for this study was that we've been hearing lots of stories, and what we wanted to do was to put numbers to those stories. And so we sought to understand the impact of elexacaftor, tezacaftor, ivacaftor, or ETI on the quality of life in people with CF. So we co-designed a survey that was intended to solicit insights regarding the experience of care and overall well-being among people with CF. Our intended audience was people with CF and parents or caregivers of a child with CF in the United States. Our survey was in the field this summer, so as some of the other studies, our results are really coming in as we speak, we're really excited to be able to present this today. So our survey had a really high response rate. 1,125 people in the community completed this, and they came from a variety of different sources. So from email sent out by the Cystic Fibrosis Foundation, from social media, as well as from invitations sent by care teams. So I want to start by just talking about the survey. The survey was co-designed by people with CF, caregivers of children with CF, clinicians, and researchers. And we were looking at 5 domains of well-being: physical, emotional, and social well-being, daily living and basic needs, and treatment burden. We were looking at this information through a couple of different ways. One was global improvement scales, so trying to understand, since you started a modulator, are you much better to much worse? And then we also included the PROMIS measures of health-related quality of life, so the global 10 for adults and the global 7+2 for parents of children. Our survey also had quite a few free text response options, and so our analysis will be a mixed methods analysis. All right, so among our 1,125 respondents, 2/3 or so were currently taking a modulator. And among this group, 80% were taking ETI, and that's the group that we'll focus on for the rest of the presentation. But we're excited to dig into the other data more fully, and there's a lot of work to be done here. So within this group taking ETI, 72% were adults, 28% were caregivers responding on behalf of their child with CF. Most people were white, a little over half were female, 68% had private insurance, 2/3 had an FEV1 of 70% or higher, and only a small number had either had a transplant or were on a transplant waiting list. So I want to start just with the very highest level picture, and this is actually, I think, kind of an exciting graph. So I'll orient you first to it. The dark blue bars are people who are currently taking ETI. The light blue bars are people who are currently taking a different modulator. The light pink are people who have taken a modulator in the past but aren't anymore, and the people in red are the people who've never taken a modulator. And with the PROMIS scores, a higher score is representing more of the concept being identified. So what you can see here is that those who are on ETI were largely similar to the United States general adult or pediatric population. And they have higher functioning than those previously or never taking a modulator therapy. So what we're going to do is progressively drill down into well-being. I'll orient you to the graph first. The dark blue bars are people who are reporting being much better since starting a modulator. The light blue are somewhat better. Gray is no change. Light pink is somewhat worse, and red is much worse. And what you're seeing here is that in general, people are reporting being much better in terms of overall health, their quality of life, their physical well-being, their experience of care, even social well-being. But when it gets down to financial well-being and mental well-being, the results are more mixed. So you have about the same number of people or proportion of people reporting much or somewhat better as much or somewhat worse. And we can look at this data in another way. So within each of these high-level domains, we also asked a series of questions, kind of like asked them to rate their whether they were much or somewhat better or much or somewhat worse in different domains. And so these graphs show the proportion of people who are much or somewhat better minus the proportion much or somewhat worse. And as you can see, in that physical well-being bucket, there are more people reporting being better than worse in all of those domains that we looked at, except for unwanted weight gain, right? And we heard a little bit about that earlier. And then in the experience of care domain, again, most people here are reporting that they're doing better compared to those who are doing worse. And the decreased frequency of pulmonary exacerbations is the most dramatic. In social well-being, people are anticipating life events. They're forming relationships and getting back out in the community. But then when you get down to those two lower categories of daily life needs, kind of financial and mental well-being, you have a mixed impact. And we're going to focus on the mental well-being for the rest of our conversation. And as you can see here, in each of our categories, except for one, more people were reporting being much or somewhat worse than much or somewhat better. And that one that was on the other side is a sense of optimism. So people are hopeful. They're really hopeful about this treatment. All right, so again, this is the same kind of graph we showed before, where you're looking at much better or somewhat better in the blues and much worse or somewhat worse in the reds. I just want to call out that we're kind of going to focus on those areas where people aren't doing as well as we might hope. And again, this is because the stories are out there that people aren't doing well, but there hasn't been a lot of conversation up to now about that. And so the areas where we have the greatest proportion of people reporting being somewhat or much worse are anxiety, agitation or irritability, thinking clearly, feelings of stress, body image, depression, and sleep difficulties. I'm going to go one step lower and look at some of the qualitative responses that we got to these free text responses throughout the survey. And again, there's positives and negatives in each of these areas. I'm going to call out some of the areas where I'm most concerned, and I'm also underlined areas that illustrate this relationship with another domain of well-being, whether it's physical well-being, social well-being, treatment burden, financial well-being. And so I'll just start with anxiety. So there's this increased anxiety, uncertainty about how I will cope with and use the extra time that I seem to have been given. And agitation or irritability. 28% of people are reporting somewhat or much worse in this area. So I have no patience for anyone. I just blow up. The blowing up is my main concern. I never know what's going to set me off. I blame this for breakup of relationships. Patients should be made aware of this. It should be discussed in clinic before you start. There should be a warning on the box. And thinking clearly, again, 28% of people are reporting somewhat or much worse in this category. So very bad memory problems. I have to write everything down. This has been really serious for me as a professor and researcher. And here again, these are the next three that are most impacted. Feelings of stress. On the somewhat much worse side, with the constant medical treatment, the financial pressures put a tremendous strain on my mental health. And body image. Since my weight gain, I've absolutely suffered issues with body image, which has affected my marriage in a negative way. I do not feel comfortable at all in my own skin. And depression, severe depression concerning living independently, change in routine, and not even wanting to live since I was ready to die from being so ill. So again, these I've kind of pulled them out because they're areas where I think we could make an impact, areas I think we can address. On the other hand, as you can see from the lighter green things, it's not all negative, right? So on the depression side, I'm so happy since I started Trikafta. My life is normal. Or the terror of never knowing when I would massively cough up blood was altering my life in such a way, or was altering my life in a way that was so negative I can't even express it. Or I don't feel like the sick person anymore. I can enjoy life and not constantly cough and be aware of everyone looking at me, especially now in the time of COVID. So we asked a lot of questions and we've been doing a lot of coding, but the kind of one of our final questions was this one around the CF Foundation is committed to supporting programs that help you achieve your best health and well-being. Please tell us the area of greatest need for you and your child regarding health and well-being. And by and far away, the biggest area that came up had to do with financial, insurance, copay, affordability issues. This is a really big concern for people in the community. And then the next area had to do with mental health. And we dove a little bit deeper into these, and some of the comments are simply mental health or anxiety. But other comments go into starting to help us think about where would we go. And so there's a handful of comments around clinical needs. While we have access to mental health assistance, addressing it in clinic is also helpful. Sometimes I think it's forgotten. And there's also a need for better research and understanding of what's actually happening. So an understanding for what's happening to our brains on Trikafta. Why are so many experiencing mental health changes, neurological changes, brain fog, et cetera? So just to conclude, our study has a handful of strengths and limitations. On the positive side, our survey was co-designed by a really great group of interdisciplinary clinicians, researchers, adults with CF, and parents of children with CF. We had a rigorous data cleaning process, and that still left us a really large sample of people within our survey. The limitations, our sample might not be representative of the larger population of people taking ETI. And of course, with everything, there's this potential confounding associated with the impact of the pandemic and other external factors that is happening. In summary, physical, social well-being, and burden of care have improved on ETI, yet still a quarter of people with CF taking ETI report worsened mental health, and mental health was the second most frequently mentioned area of need. So we hope that these surveys are laying the groundwork for establishing future research priorities, policy efforts, and communications. So that's all I have.
Thank you so much to all of our great presenters. Definitely very exciting topics, so thank you. And we have lots of questions, so I'm glad we have time to get to them. So maybe, I know it's kind of clunky, but maybe we'll still ask everybody just to come up here and might be easier kind of, yeah. All right. So the first question is for Eric, as you're coming up. All right. In terms of discussions about reproductive health, is there any thought to also include discussion with patients about access to abortion care, especially in light of the lack of access to this healthcare necessity? We're just going to jump right into it, you know?
Yeah, thank to whoever put that question there. You know, certainly that is part of what I think would be well-rounded healthcare, is discussing that. In certain states that have decreased that, we work really hard, which is in Florida where I live, we worked really hard to just find other options for that. And that does need to be part of that, the discussion, and future talks about those types of things. They're sensitive, but, you know, they can be done. And again, it's not about us staying comfortable, it's about what the patient needs from us.
The next
Okay.
question is for Eric as well. So this says, how have other social workers and physicians counseled young men who would like to have biological children but don't have access to financial resources? I find that most insurances, especially Medicaid, don't cover sperm extraction procedures, even if they do cover IVF for women.
Yeah, so there's definitely a discrepancy there. I don't think in my clinic I've heard of anybody really addressing the inequity with that. Being a social worker by trade, you know, it's going to be really hard for me to just rest on that. So that's another area of exploration as far as any financial assistance that would be coming up. What I wanted to note is, you know, some of the boys at 16, 17 were like, well, I'm not going to have kids now, you know, and I said, I know that, and I'm glad to hear that, you know, for the most part, but we want to make sure that you've got this information moving forward. So as our conversations continue, and again, it's just kind of like when we start out on mental health, they're now more comfortable bringing up questions. This will be just another thing that might fall into that. And when they elicit questions, it's just going to get me to work harder. So.
The next question is for Dr. Gross. All right. So there were a lot of questions about CBD and cannabis, so we'll start. So for the participants with CF who used cannabis for sleep, do you know what form they were using? Smoking versus edibles versus tinctures?
Yeah, that's a great question. So in our study, it was 100% reported using edibles for sleep purposes. I'll caveat that with some people use multiple forms, but specifically for the goal of attaining sleep, they're using edibles. So I come from Colorado, which was the first state probably most people know to legalize marijuana. I think the last I heard, it's over 50% of the states have some form of legalized marijuana now. So I think this is definitely going to continue to be an issue. Patients are looking to this for treatments for various things, and certainly including sleep.
Thank you.
So now we have a couple for Dr. Lyons. Actually, if you wanted to stay up there, Dr. Gross, we'll skip to some of the other CBD ones so that you're not coming back and forth.
That's okay.
Was there any breakdown in terms of CBD or marijuana usage for sleep on a CBD use with no THC versus THC use? So that's part one of the question, like breakdown of CBD versus THC, and then also about the route of administration, such as inhaled or pill, et cetera.
Right. Again, so for the purposes of sleep, it was always edibles. But we do know that our patients are using marijuana in other forms. Fortunately, the vast majority are still just using edibles, but there's about 20% in our cohort that were smoking marijuana in various forms, either, through like bongs or pipes or things like that, as well as vaping. So in that age group, especially, vaping is, very popular. And so that's true for both nicotine and marijuana as well. And the first part of the question was the difference between CBD versus marijuana. Yeah, and so in our case, everyone was using marijuana plus or minus reporting CBD use. And I don't remember off the top of my head the breakdown of CBD alone. But for the people using it, they were all universally using marijuana as well.
is it possible that the increase in anxiety observed is related to more opportunities and uncertainties versus, kind of the effect of the medication? Right, in the past, they knew that the health would decline and the patients would die early, and now it's less certain.
Yeah, I think that what's happening in mental health is probably really multifactorial. I think that there's this interrelationship with so many different aspects of well-being that we can try to sort out a little bit. I think having, the fact that our survey does go into detail in each of these domains of well-being will allow us to start to see what patterns exist in terms of, interrelationships. But I'm also really curious, is there a biological mechanism that we need to be looking at? So I think that we have the opportunity to start to understand this, but as I said, we're just starting into analysis of our work, and it's really pretty exciting to see what we can start to pull out.
All right, now we have some questions for Dr. Lyons about body image. So for the first one, how do you approach patients who are disappointed that they haven't gained any weight in Trikafta, especially when they're hearing about so many people gaining too much weight?
That's a great question. I actually saw, this is making me think of a patient that I saw for outpatient therapy who was a male and, kind of severely underweight and was disappointed that he wasn't gaining weight. And I think, it takes a lot of validation, obviously, of, what patients are experiencing and how they're feeling about it. And then also, providing some element of hope. And then also acknowledging that some patients aren't responders. And really kind of staying in touch with the medical team and getting, input from different team members about other aspects of treatment that could be hindering this weight gain. I think that's where I'd start.
And then we have one more while you're up there. Do you think there are likely specific barriers to implementing intuitive eating or like the healthy body at any size with CF patients? And how do you think these barriers could possibly be addressed?
Yeah, that's a good question. I think that's an area where we need to start thinking a little bit more in depth about what the future looks like, especially with weight gain and how nutrition recommendations may be changing. I think, there's a really long established history and specific guidelines around caloric requirements and nutrition that I think is really ingrained in how we deliver care around nutrition and in our teams. So I think, I think there's a lot of work to be done on this, and I think it's going to take a lot of collaboration with everyone to figure out the best direction for the future. But I do think that, it might be worth considering how to start addressing these issues earlier, and while also, still adhering to what we know to be true about nutritional requirements of young children with CF, maybe start to help families begin to think about nutrition in a different way than maybe we have in the past. And again, I think that's going to take some collaboration and brainstorming about how to do this with everyone on the team moving forward.
There's one more. Yeah, there's many questions, but this one got voted up. So, in examining the impact of Trikafta, did you notice for those endorsing changes in body image any correlated mood change or a more significant mood change than those whose body image was not affected?
That's an excellent question, and I want to say anecdotally yes, but I have not analyzed that data. So we have PHQ-9 and GAD-7 data from all the patients included in this study, and I am interested in looking at any relationships between those data points, but I have not looked at it specifically. In my experience, yes.
The next question is for Dr. Lyons. What objective measures of adherence are you considering in future steps? Oh, I guess, yeah. So back for you. Yes.
Yes. I am considering possibly maybe pharmacy refill data. And I also think, this isn't objective, but I'm also thinking of possibly involving parents, because this was adolescent self-report, perhaps getting the parents involved and thinking about ways to integrate their report as well. Again, this might not be as objective, but it could just be another data point to clarify what's really going on with adherence. Okay, is that
Thank
it?
you. Okay, for now. Okay. All right. Okay. All right. So next question, we're talking about sleep. So do you have information on iron levels? Given the association between lower ferritin levels and restless leg syndrome, what are your thoughts about including iron studies as a part of our routine monitoring in patients with CF?
That's a really great question. We did not explore that at all, since this was just a questionnaire-based study at this point. We are proposing to do a more formal pilot study, including laboratory evaluations and formal polysomnograms moving forward. So I don't have an answer for what we studied this time around. I will say that at least in the Denver adult program, we do get iron panels and ferritin both on an annual basis. That is part of our routine laboratory evaluation. I can't say that that's true for everyone, but that is what we do for sure. Okay.
All right. Another question, did you control for patients receiving therapy for insomnia?
That's a good question. No. You know, we did query what medications patients were prescribed, and so there were patients prescribed tricyclics, for example, presumably for insomnia, but we didn't necessarily make that direct link. But if someone's taking amitriptyline or nortriptyline, we presumed that was the reason, just based on our clinical practices. So we've not pulled that out as a separate factor at this point.
And then one more, do you have any thoughts about why Trikafta would have impacted sleep for the better or for worse?
Yeah, that's a good question. You know, I think prior to ETI therapy, you know, patients said in part, you know, their sleep was disrupted by the physical symptoms of CF, right? Coughing, mucus production, gastroesophageal reflux, and then pain, right, which may be related to CF. So I think, you know, you would expect that those symptoms would improve with the use of ETI. However, things like anxiety and depression were also common complaints as to why they couldn't sleep. And as we've learned, you know, in some cases, that's actually much worse on ETI. So you might have a mixed effect, I think, in that group, whether you had those symptoms improve or whether they did not, and in fact may have worsened.
All right. So I guess next question for anybody who wants to take it. So we had a post-transplant patient who was prescribed Trikafta. She took it for a short time, felt better, but discontinued it due to weight gain. Any suggestions on how to encourage her to re-engage with Trikafta? Maybe about decision-making?
Yeah, that's a good question, and I'm not going to directly answer it, but I think that's why we need to understand how to have these conversations with our patients, right? That's, our perception might be that the benefits outweigh the cost, but we shouldn't be assuming, you know, what's important to our patients, and I think there's a way for us to ask questions and understand where they're coming from, and then perhaps get to an outcome that is different than being, okay, I'm taking it, I'm gaining all this weight, or I'm not taking it. I think we need to understand how to talk about these things with our patients, and that's one hope with our study, at least, and one reason why we undertook it, so we know what to ask, how to facilitate conversations, and how to help patients figure out what they need to be as healthy as they can be.
All All right, I think this question is for Erica, but if other speakers want to add in, they can. What can we do to encourage clinical trials or TDN observational trials to include questionnaires on mental health so that we can have the pre and post highly effective modulator effects on mental health?
So great question. I think that one of the things I'm excited for with the WellMe study, which is what our study is called, Wellness in the Modulator Era, is that it is supported by the Cystic Fibrosis Foundation, and the foundation has, their senior leaders who are aware of this work. It's embedded in, all the conversations are happening across the board at the CF Foundation. And so I think there is an awareness, and given the connection between all of those different networks and the foundation, I'm hopeful that this helps to set the stage. Really, the intention of our survey was to identify where are there these gaps, and how can we start impacting policy decisions, research priorities, and communication. And so that really was the impetus for this study. And I'm hopeful that by having this information, they can actually make decisions that go in that direction.
I also want to add, if there is anybody in the audience who wants to ask a question verbally, you don't want to use the app, or you just like to discuss, feel free to raise your hand as well. All right. Oh, yes.
And we do have more questions related to weight. I think Dr. Lyons. In terms of the weight gain, right, observed, is it good weight? And how much weight is typical?
That's a great question. I'm confused about what good weight means, but I also don't know how much weight is typical. That's not something that I am totally familiar with, so.
I guess that's fair. Okay. Yeah, I don't know if anybody else wants to contribute to that.
Eric, we have a couple of questions for you. And so one of them is, have you considered use of a sperm count to assess for fertility in males with CF in lieu of ultrasound? Sometimes the VAS can be present, but not patent.
Yeah. I need to go to medical school before I can answer that. Certainly, any option to improve, the outlook or the hope in the patient, and if that's one of them, definitely. I will definitely be trying to contact some counterparts in the adult world just to kind of see what they're doing. Our study was really preliminary, saying, hey, these are the things that you're going to need to start thinking about. And we kind of stopped there versus carrying it on because, like I said, a lot of the patients are like, wait, I'm not having kids now, so.
And that links with another question, because you mentioned of just starting those topics. How do you approach infertility with adolescent males? Do you consult with the parents first or just dive into the conversation?
I felt like it was important for me to give an overview of what we were aiming to do. Just an introduction instead of just walking in and handing the iPad and saying, okay, we want to know what you know about having kids in your life. I did that by the email, which I felt like I went in depth about the goals, but also some of the limitations. But then just inviting questions before actually administering it, and then of course staying with a follow through. And with the ease of administration and the time it takes, I found it very doable to do within usually the 10 or 15 minutes that I get with a patient. It was enough time. Yeah, I don't have any awareness of that when it comes to insurance, but that's a great question. Okay, thank you.
Okay. All right. So I think this is the question for Kimberly or Erica, maybe. So what can we do to encourage clinical trials or TDN observational trials to include questionnaires on mental health so that we can have the pre and post HEMT effects? Oh, okay, we did that one. Okay. I did not check it out. Great, thank you. Was there any other new answers developed since? Okay, I think, yeah, do we have?
Yes, because I just checked in the discussion tab of the app. So for people who are putting in questions, there's also a number of comments in the discussion tab with like calling people's attention to different resources. So definitely there's a number of resources that people have submitted in the discussion tab, but we have some questions as well. Did somebody have their hand up? Yes, go ahead. Yeah, so it sounds like from what people are saying that some centers or some people are reporting and then still, sounds like waiting for perhaps more from them and certainly more studies so that we can start to have more information and data to help our patients make these decisions and to try to understand what's going on.
I think that, when you start looking across all these studies that are out there, I think there's real triangulation that there is something happening, and the cause of it, I think, needs to be determined, right? It could be many different things causing it, but from a clinical point of view, it's a big deal and needs to be addressed. And I think that's kind of that need statement question that the survey asked is really an important one. Like, we need to be paying attention to mental health. It needs to be something that clinically we're addressing and that from a research side we're addressing. So it's really a two-pronged thing as I see it.
Yeah.
This is really encouraging and something that I will go back and tell the CF community. Thank you for the data. Thank you for the data you're going to be doing, because it's really hard to go crazy when you're seeing it in your home and you want nothing more than to be with this message you waited so long for and helping your child, and you're finding, instead of dealing with CF, which you know so well, you're now finding yourself in the mental health department and having to navigate a whole new thing to be a part of. So, thank you. That's all I want to say.
Yes, thank you very much for sharing that. And before I go to the next question, some of the resources noted in the discussion, that there's tips for care teams about psychosocial considerations of Trikafta, pediatric and adult versions, and there's also a tips for care team conversations about body image, certainly a very important one. And all of these tip resource sheets are found in the resource library at mycff.org, or you can email the Mental Health Advisory Committee at mentalhealth@cff.org. And I think we have a number of the Mental Health Committee members here as well, so after the session, they might be happy to talk about some of these as well. A question that I think this could be perhaps for a number of our presenters, are more folks considering screening for brain fog, specifically, for example, and then like using the PROMIS, for example? Because we've talked a lot about some of the other side effects.
I mean, I would be interested in trying some of that, but I have not been screening for that.
Self-reported?
Yes.
Okay.
Okay.
Yeah.
One possibility, a 90-second screener, single-digit modality test is available. If you wanted to use screening of brain fog or very quick, you can do it online, Zoom, and auditory presentation, both with your patient and admitted, and it looks at short-term memory and processing speed. So if you wanted to become this very brief, I mean, it's 90 seconds, it doesn't cover all the full neuropsychological battery, obviously, but just a suggestion.
you.
Thank you so much. And I'm just going to say that I'm also having a roundtable after this. We're going to be just really brainstorming and discussing about cognitive tissues in CF. So if anybody wants to join, so that we can continue conversation.
So this is a question, I think, for Dr. Lyons. And it says, we recently had a mom comment about her daughter's weight and how she had lost weight since they both had started a new diet. Our team was concerned about this comment being made by the parent and not wanting that thought to get planted in our patient's head. Do you have any recommendations on how to respond in these kinds of situations with families who might be overly concerned about weight? And they just put of note, like this patient is a healthy weight.
Yeah, yes. Yes, this is something else that I'm interested in, possibly for future research, is how do parents, issues with their own weight and eating impact their child? And I think it's worth having conversations with parents about, really emphasizing that they are the best models for their children, and the things that they do and the things that they say, especially around eating and weight, are incredibly impactful. And I think it's okay to talk, kind of directly with parents about this in a very non-accusatory way, but being really open and non-blaming and questioning and all of the things that we as mental health providers are really good at. But really, reminding them that what they do and what they say is impacting their child. So I have had conversations with parents like that, and it's actually been pretty elucidating for parents, and I think also really impactful. So, I think this is really important and something that we should be talking with parents about.
There's some more questions coming in. Also, I just saw the comment for the people in the back. We'll try to repeat the questions that people are asking verbally so that you can hear. This one could be for a number of the presenters. Is it possible that the increase in anxiety observed is related to more opportunities or uncertainty in the past? Oh, did we do this one? Okay, great. All right. Any more questions from people in the room?
More comments?
This is for Eric. I'm wondering if in light of growing age, if that lends any sense of urgency for providers to have more conversations.
It's a hot topic in Florida. It's a sensitive topic. I think in our clinic there's views for either way. I know for me personally, trained as a social worker, it's to help people get their needs met despite challenges. So I would probably be driving that conversation along with the social worker. I'm the mental health coordinator. I have not heard any specifics about that. We did have one patient who was 17 who conceived and was considering terminating the pregnancy. The social worker worked with her, but she ended up miscarrying before that. So that's as close as that I have as far as during this time in this study. So, but thank you for that great question.
Thank you so much. First of all, I would like to thank all of our presenters. This has been an incredible symposium. And thank you everybody for attending and asking questions and commenting and engaging, and enjoy the rest of your day. Okay, thank you.